And welcome everyone. Welcome to those of you joining online. My name is Cyan and I'm Health Equity Lead here at Stanford Biodesign. Those of you joining online would love to know where you're joining from. Please pop it in the chat. You will also have an opportunity at the end to ask questions and engage with us. For those in the room, you are welcome to have some snacks and eat while we have this. It's meant to be conversational and informal. Just some background about the series. So this is the start of our Health Equity and Innovation series. They run every academic year from August to April. And the idea is that it is a good catalyst for conversation, for learning about the topic of inequity and innovation, and for us to hear different types of speakers and different types of projects. So I'd just like to thank our partners, the Center for Innovation and Global Health, the Bay Area Global Health Alliance, and the Stanford Global Health Graduate Network. Some housekeeping before we begin. Please just put your phone to silent if you are joining us in the room. And you are welcome, as I say, to help self snacks. And just a big thank you to everyone who makes these webinars possible, to Deja, to Danny, and to Antia. They're the team that makes these events possible every month. And I'm now going to hand over to Krista Donaldson, who's going to introduce you to today's speaker. So over to you, Krista.
Thank you, Cyan. So hi, everybody. I know many of you, but I am Krista Donaldson, the Director of Innovation to Impact here at Stanford Biodesign, and welcome to our new year of series, our 2025, and we have a fantastic speaker today to kick us off. I am thrilled to introduce Dr. Tracy Johnson. Tracy is an internationally recognized design anthropologist, and in my opinion, and Tracy, I rewrote some of your bio. Sorry, I hope you don't mind.
Don't mind.
She's really one of the giants of design and global health and health in general. But she's an expert beyond that, also looking at social impact. And she's led a number of efforts. Some of you may know, for example, the designforhealth.org website. If you haven't seen that, check that out. But she's led multiple initiatives to bring user-centered design processes to solving complex social problems. At the Gates Foundation, she drives an agenda for bringing together the power of design to disrupt notions of data. To disrupt notions of data as objective and data science to bring statistical power and novel discovery. She holds a PhD in anthropology from Columbia University and has contributed to a really cool book. It's called the LEAP Dialogues, Career Pathways in Design for Social Innovation. I know many of you, especially our students and our fellows, have expressed an interest in different career pathways. Please check this out. Today, she will be speaking to us about the Pathways Project, which has a very dear part in my heart because I think it's so incredibly innovative and brings together health, it brings together segmentation, business, and user research in a way that provides incredible nuance around user needs and research. What Pathways is it provides women-centered data, evidence, and tools to uncover underlying vulnerabilities. And it uses a segmentation approach to better understand how health outcomes are distributed in a population. And so for many of you who are interested in designing for different user groups or different populations, this really helps you understand how much impact are you having or could you have? And so this is already being used by governments and donors and different types of implementers to inform strategies and design health solutions to consider social determinants of health, prioritize services, and integrate health programs across communities and across different communities. But the idea, again, is to enhance and do better with impact. So with that, I will hand it over to Tracy and welcome.
Thank you. Thank you so much, Krista. Thank you, Cyan. Thanks everybody for having me. It's exciting that this is the beginning of the program, I guess, for you. You guys are just getting started. So hopefully some of what we talk about today will hopefully help you think about the program that you're about to embark on. So I'm going to talk to you today about the social determinants of health, how we think about vulnerability, how we think about all of this in relation to health equity, and how we've brought that together in a program that we call Pathways. Great. So yes, I think before I jump into sort of the various things that I want to talk to you about today, I thought maybe I'd share just a couple of minutes of Hassana's story. And Hassana is one of the many women that we met throughout Nigeria, Kenya, and Bihar and Uttar Pradesh states in India when we started this work that we call Pathways. So listen to a couple minutes of Hassana's story and just maybe keep her in mind as we go through the rest of the presentation. So maybe start the recording now.
Warawa, a rural community in Kano State, with my 5 children, husband, and 4 wives. My husband now has 4 wives, including me, and we all live together with our children. My husband is the sole earner in our family. He works hard, but sometimes it's not enough for all of us. He sells pepper and vegetables at the market. I try to help by knitting caps to sell, but the money from that is not regular. I was born in Ringingado community in Kano State, where I live with my parents and siblings. My mother is the second wife of my father, and I am the 5th child of 7 children from my mother. Overall, my father has 18 children. There used to be so much work in the house growing up. My older sister Hassana was like a mother to me and taught me everything I know. But with so many of us, I sometimes felt lost in the crowd, just another mouth to feed. My father only believed in sending my brothers to school, so I did not go. I attended the local Islamic school, where I learned to recite the Quran and basic Arabic. I was taught to be a good wife and mother and to obey my husband. At home, my mother and aunties were my other teachers. They will show us how to pound millet, prepare the dough, and knead dough for masa. I learned that the woman's strength is in her home. As I grew up, my mother and aunties watched me closely to make sure I behaved appropriately as a young woman. Nobody told me about menstruation before I saw my own at age 12. The day my mother saw me cry, she saw the blood and said I had now become a woman. She told me how to clean myself and gave me the clothes and rags, whispering instruction on how to wash and dry them secretly. Never let a man see this, she warned. I got married at age 14 to my husband. My parents chose him for me. When I got to my husband's house, he already had a wife and children. I used to cry a lot and I did not talk to my husband. Even when he tried to talk to me and come close to me, I would just be quiet and ignore him. My husband was twice my age and I couldn't help flinching away from him. My co-wife Halima was older than me by several years and had 5 children. She was kind, but distant. I lost my second child after 3 months. I gave birth to her 1 year after I gave birth to my firstborn. I had barely recovered from my first birth when I found myself pregnant again. The pregnancy was difficult. I was always tired and often sick. When the baby came, she was so tiny and looked weak. I took care of her for 3 months, but one morning I found her still and cold. It was a very difficult time for me, and I felt so alone. My husband was sad too, but he didn't show it much. We didn't talk about it, and I eventually felt better after I got pregnant again. Over the years, my household has grown and changed with 4 wives and plenty children. It is delicate navigating the relationships between co-wives and stepchildren. Sometimes there is tension, especially when resources are scarce, but we have learned to support each other too. My relationship with my husband has grown. He's not an unkind man, but if I don't do what he wants, he gets angry and sometimes disciplines me. As my parents taught me before marriage, it is his right. We struggle to make ends meet, especially for food or when the children need things for school or when someone falls sick. My husband leaves at dawn for the market. His wheelbarrow loaded with vegetables. On good days, he returns with enough money for our daily needs. On bad days, we go to bed with empty stomach. I have learned to stretch every naira to make meals for almost nothing. My knitting brings in a little extra, but it's never enough. I don't go out without my husband's permission, even to the hospital. It is just how things are here. I only socialize with few people in the community. Sometimes I feel lonely, wishing I could visit my family more often or make new friends. But I know my place is here, taking care of my home and children. When someone in the family is sick, we usually visit the chemist first. It is closer and cheaper than going to the hospital. I have given birth to 5 out of my 7 children at home. Sadly, I also lost my 7th child at birth due to complications. It is difficult to get permission to go to the hospital for my husband. He thinks the chemist has all the drugs he will fall sick. I do go for antenatal care visits when I'm pregnant, but I still believe it's okay to give birth at home. That's how most women in our community do. As for family planning, I don't believe in it. Children are blessings from Allah and don't mind having more. My husband wants a large family too, so we are in agreement with that.
So that's just a very short example of or an encapsulation of Hasana's story. And Hasana comes from, as we'll talk about in a little bit, one of the most vulnerable segments in all of northern Nigeria. I want you to keep the elements of her story and the pieces of vulnerability that she referenced in mind as we run through the rest of the presentation. But maybe Cyan, move on to the next slide. Oh, this is not the updated deck. Okay. So we'll do this a little bit differently. Okay, before we jump into pathways, I will just I want to go over sort of a few areas and a few sort of definitions of things. So one of the things as an anthropologist that's really important to me is how do we actually really think about the social determinants of health? And that's what you see here. It's education, economic health, where you live and your built environment. This is the social and community context in which you live your life. Next slide. But the social determinants of health, while we know that they are very, very critical for one's health, they've been really challenging to address through global health. I think that, a big part of that is basically how our field is actually structured, which ends up resulting in a lot of silos. So we think about maternal health separately, then we think about family planning separately, then we think about child health, and so on. And what this leads to is a fragmentation and an inability to, if we think about Hasana, to really think about her whole life, the whole of her life, and how everything from her childhood through whether she's prepared for her, as she says, she's not prepared to menstruate the first time, whether she's prepared for sex after she gets married, all of these pieces all the way through to giving birth, raising her children, and so on. And so because the global health field sort of leaves these things siloed, we can't really find a way to actionably address the social determinants of health. And Pathways, as we'll talk about in a minute, is really an effort to address that gap. If we go on to the next slide, I think the other sort of the second of three issues that or sort of things I want to define for you today is vulnerability. So the way that we think about vulnerability in Pathways is first, it's a quality or it's a state. So it's a characteristic that is present in a certain set of contexts, which means it makes that person within that context vulnerable. And it can happen at a point in time, but it often happens over a period of time. When we think about vulnerability, we also think about it is the thing that means you are going to be exposed to the possibility of being harmed. And what that means is that with vulnerability, we have to think about how do we predict it? How do we understand what is the probability that someone is in the future going to likely experience a type of harm? And in the case of, as we did this work to develop Pathways, we thought about 4 areas where vulnerability was very critical: physical, emotional, social, and cognitive. And we touch on all of those. If we go to the next slide, one of the things that one of the things that I think was important as we started to think about vulnerability is we wanted to think about what were those drivers that produced vulnerability in a woman's life. And how did that change sort of the trajectory of her life? A lot of people have asked me why we use vulnerability and not resiliency. And I'll be honest, when we started this work, we thought we were going to we were looking at vulnerability as a way to get to resiliency. But the reason that we never switched to resiliency is that we actually saw oftentimes people do things in their life in the name of resilience that actually leads to greater vulnerability in the future. So we ended up sticking with this notion of vulnerability, and we thought about how do we reduce risk? How do we mitigate risk? How we lower one's exposure to risk? How we manage risk over time? And how you cope with risk or vulnerability once it's actually happened to you. And we started turning those into a design question, which is something that you guys might cover a lot in this class coming up. But we turned them into a series of how might we's. How might the health system respond to vulnerability, support its reduction? How can it anticipate vulnerability? How can it help people avoid exposing themselves to risk and so on? And then if we go to the next slide. The third issue that I want to talk to you about it before we get into Pathways is the notion of segmentation. So segmentation is really just a tool. It's used a lot in the private sector, and enables you to divide a population into smaller subgroups that share characteristics, and that enable you to respond to those subgroups more directly, as opposed to thinking about something on a population level. The things to know about segments is that they are mutually exclusive, so you can't belong to more than one segment at a time, and that they form an order. They can be ranked according to your particular dimension of interest. When we started Pathways, we knew that we wanted to segment on this notion of vulnerability. And it was really an experiment. We didn't know if we were going to be able to go so far, as we say, upstream in the global health world to really go back into the entirety of a woman's life and understand what were those things that drive vulnerability and how can we segment women on the presence or the absence of those drivers that lead to vulnerability in her life. Next slide. And maybe actually, sorry, this is a build, so maybe click through at least 2 more times and 1 more time. That's great. So in my experience within global health is that we often think first and foremost from this biomedical and clinical lens, and we apply disease strategies to develop and design products and interventions that will address and manage the health risks of women in their reproductive years. Because global health is trying to work on a population level, we often sort of look for that lowest common denominator among the population and respond to that. What we end up doing is we really end up creating one-size-fits-all interventions that treat women more homogeneously through the notion that they share certain characteristics, usually around their reproductive roles. The other thing it leads to is that we look for easy to measure or easily observable indicators. So we look at things like a woman's age, what is her life stage, what is the parity of a woman, how many children does she have? And we sort of characterize women on those very sort of easily observable and easily measurable indicators that really belie the deeper root causes that lead to her vulnerability to poor health. The third thing that I think that we leads to not the best interventions, let's say, is that we treat risk and harm as a moment in time. And so we think about the woman, and again, this is sort of more from a disease strategy perspective, but we think about that woman presenting in a facility. What is her most immediate problem, and how do we need to address that? Obviously, we need to address that problem, but at the same time, by seeing it as this one moment in time, we fail to take into account oftentimes the complexity of the trajectory that that woman's health has taken over time. Next slide. And click through 2 more times. Yeah, thanks. So we created Pathways as a way to use segmentation to see if we could provide the field of global health with different strategies that would drive what we hoped would be more transformative programming to really address vulnerability head on. And we see this as happening in 3 different ways. The first way, we like to refer to Pathways as enabling us to do precision global health. So we can really focus on a particular segment of women, think about the vulnerability that she carries, the burden that she carries, and tailor our interventions for her and her segment specifically. So you can think about Hasana, the prevalence of home birth. You can also think about segments that are likely to have 0-dose families. And just as sort of a teaser, these are usually actually the same families. So we often don't think of home birth and vaccination in the same thought, but actually the women who are vulnerable to having a birth at home are the same women who are vulnerable to having a 0-dose child. The second way that we can use segmentation to more effectively target women is thinking about how we might want to develop intervention packages to reach multiple segments. And so we'll have an example later on of work that we've done in Nigeria that tries to reach the group of most vulnerable segments. And then lastly, what we like to say about thinking about segmentation is that we're being more inclusive. We're really understanding what it is that women need based on their different health trajectories and how we can be responsive in a more inclusive and thus equitable way. Next slide. Pathways is, Krista mentioned, it is a resolutely design-driven approach. What that means is that we are constantly iterating and constantly learning, not just from the women that we're trying to serve, but also the field and how they're using pathways and how do we need to adapt it to be more responsive to them. It's women-centered, so it starts with women, and you don't necessarily need to have a discussion about whether you're going to do something like human-centered design or not. If you start with the women's story, you are being women-centered, and you are starting with her as opposed to that final intervention or that new product that you're trying to introduce into the world. I mentioned that we're trying to be more precise, so we're really trying to address women's needs as they articulate them, and we take this vulnerability lens to ensure that we are being more equitable. Next slide, please. This is just a little bit on methodology. I won't spend a lot of time here, but just to say for those very strong quant people in the room, we go through a very rigorous process when we collect data for pathways. We can either deploy a pathways survey, or we can use an existing data set such as the DHS. We do exploratory data analysis, we do principal components analysis, and we do latent class analysis. And that is what drives the segmentation. So it's all to say, for those people for whom those terms aren't familiar, we do not decide what to segment on. We let the data tell us what it is that segments women according to vulnerability. And in the next slide, you'll see that we also bring, in addition to the big data through large N surveying, we also use what we like to call thick data, which is that more qualitative data that really looks at behavior, cultural dynamics, all of the things that quantitative data finds harder to assess. And we bring those together in the segmentation and in the profiles that we create for these women. Next slide, please. The framework that we use is nestled in the notion that vulnerable women are vulnerable in different ways. So we look at 6 domains of a woman's life, and this was informed by a year of qualitative work in the original geographies of northern Nigeria, Kenya, and the 2 states in India, Bihar and UP. We've since expanded our geographic footprint, but that's where we started. And we developed these 6 domains. And for those of you familiar with the socioecological model, this may look somewhat familiar to you. But we start with the woman in the middle, and we think about her and her past experiences. So think about Hasana's childhood. Was she educated? Did she experience hunger as a child, and so on? We also think about her health mental models. I like to think of this as, is health something you actively do, or is health something that passively happens to you? We then go out to the next level and we think about household structurals, social structure. So what are the relationships in the household? What are the power dynamics? Who makes decisions? And we also look at the economics. Who works in the household? What kind of money do they bring in? Again, who makes decisions about how to use that money, and so on. The next level out is the community. So we look at things like social support, belonging, whether the woman feels that she can rely on her community for health and support, and so on. And then lastly, we look at the human and natural systems. So think climate change, migration, economic crises, and the like. These all provide the profile of the segment that the woman falls into. And they also dictate, does she follow a more resilient pathway or a more vulnerable pathway to a set of behaviors that ultimately result in reproductive, maternal, newborn, child health, and nutrition outcomes. Now, it's important to realize that the health system often only sees that behavior that drives a woman into the health system, and fails to see all of those components of her life in the background. And so what Pathways does is helps you, whether you are a provider at a facility, whether you are a community health worker, whether you're a state health official in Kano State, for example, with Hasana, or whether you're a funder thinking about how to spend your money in global health. It provides you with a better sense of what is it that makes a particular woman vulnerable at a particular time. Next slide, please. The health outcomes that we look at are quite broad. You can see the list here, and I'm looking at the time, so maybe we'll jump to the next slide, and I'll go through a couple of these slides very quickly. We look at the life course. So as I said, we don't think about this sort of moment in time health event, but we look at the life of the woman from her childhood through her reproductive years. Next slide. So this starts to get you a sense of what the data looks like and how we can think about it in relation to health equity. So here we're looking at, and this is a snapshot of the projectpathways.org website, which is being developed and launched as a global public good. It will be officially launched in October at the World Health Summit in Berlin. But essentially, this is a behavior that we look at within the maternal health area. And you can look at home birth, which is one of the leading precursors to infant mortality. Now, oftentimes we think about home birth on a national level, or perhaps on a subnational level. For example, we look at the states in northern Nigeria, and we look at the representativeness of home birth. With Pathways, we can go well beyond that, and we can look at what segment does a woman fall into, and what does this tell us about her likelihood of giving birth at home. In northern Nigeria, R4, which has the highest percentage of home birth, is 17 million women. U1, so R4 is rural, 4 is most vulnerable. U1, right next to her, U is urban, 1 is least vulnerable. That's about 600,000 women. So when we think about that, the burden of home birth, and as we'll see, Cyan, please go to the next slide, all of the other outcomes related to that, we start to see this notion of certain women, and in the case of northern Nigeria, the largest percentage of women, really carrying the heaviest burden. So this quickly gives you just a sense of a perspective of all the different types of data. And this is really just a tiny snapshot of all the data that we have in Pathways. It gives you the segment on the left-hand side. You can look at the total percentage of the population and her modern contraceptive uptake, the likelihood that she would have an under 5 death in her household, the behaviors associated with that, such as home birth and ANC, antenatal care, and then the differentiating vulnerabilities. So her education, what's her wealth quintile? Does this woman work? What's her decision-making power? How much she's internalized domestic violence? Whether cost and distance are a barrier for her to get to the health system, whether she belongs to a savings group, and what does her digital connectivity look like? And you start to see how that is incredibly varied across these. And again, you're not looking at a population level, but you're looking at a population representative segment. So you're much more granular and much closer to the specific woman, such as Hasana. Next slide, please. I'll run through these just quickly. On the left-hand side, again, you see this is northern Nigeria, and you see the likelihood of internalization. Sorry, this is Senegal, excuse me, the S refers to Senegal. So R4, again, the most vulnerable rural segment. She's really internalized all of these, she's internalized many gender norms. So she believes that domestic violence is justified in many scenarios, going out without telling her partner, neglecting her children, arguing, refusing sex, and something as mundane as burning food. But you start to see sort of how much she's internalized these gender norms in relation to other segments in Senegal. You can also see things like the trajectory. And again, one of the things I said earlier is we like to project or predict vulnerability. So you can look very quickly at this notion of age at first cohabitation and what that means in terms of the trajectory of how many children she's likely to have over the course of her life. Next slide. One of the things that people have said is we have other targeting methods, and we think about things like wealth quintile. Wouldn't that just be easier than something like segmentation? We compared pathways to targeting by wealth quintile, and you can see on the left-hand side U4, the most vulnerable urban segment, and an R2, a rural less vulnerable segment, that they actually have roughly the same wealth index. But on the right-hand side, you see that their decision-making and the likelihood that they have a child who's died under 5 being quite different. So wealth index isn't really in that case telling us all that much, whereas the notions that are caught in the segmentation are telling us something more substantial about her actual behaviors, such as can she make decisions for herself about her health and whether she's had a child who died. Next slide, please. This slide just quickly gives you a sense of the interpartum care journey. So on the left-hand side, you see the northern Nigeria segments, according to starting at most vulnerable down to least vulnerable. And you see how their behaviors from uptake of family planning through vaccinating their children. You see how those behaviors group together where they are struggling to achieve the outcomes they want in those areas and where they're not, and how we might intervene differently. Next slide, please. Something like this, actually, in Pathways, we can connect what we call lives and livelihoods. So health outcomes such as under 5 mortality, with whether or not she owns a mobile phone and whether or not she is actively on the internet. And you see the comparisons across northern Nigeria and Senegal, Senegal being one of our newer geographies. And you can see very clearly how burden really rests within those women who are not connected, don't have phones, aren't using the internet, and so on. I'm cognizant of time, and we have several more slides, but Cyan, Krista, I just want to open it up to you whether I should keep going or whether we should open it up for questions.
I think it would be great to stop there and open it up for questions, Tracy. We have about just over 12 minutes for questions. So I think
Great.
For those joining online, you can also submit your questions, and then for those in the room, you can also go ahead. So are there any questions to kick us off? Matthias, do you just want to say your name and where you're from and then ask Tracy the question?
I'm Matthias from Belgium, living in the States for about 5 years. So my question is, this seems like really interesting to create like a lot of correlations, and you kind of group people based on correlations. But I'm curious, how do you use this to really look at the causation of the root cause of this? I come from a product perspective, so you would almost say like a persona. So I'm really curious.
That's a great question, Matthias. I will tell you, I think personas have an important role to play. I often also think that because you are already in that product design shoot, if you will, you can end up very much flattening the personas as you're thinking about your one particular product. So the thing that Pathways is trying to do is borrow from the notion that we can create create archetypes, or we can create profiles of groups of women. And then how do we design with their barriers in mind? So for example, we might design, I work on a program to design an intervention that delivers micro multi-nutrient supplements to pregnant women. Now, the women that these MMS, as we call them, is going to serve most are those women who are probably already vulnerable. They may have poor nutrition, they may have had poor nutrition throughout the course of their life. They may not have a lot of money, so they can't buy sort of food supplements or vitamins that are needed for pregnancy on their own. And so we want to deliver MMS. We end up delivering it through the health system. But when we look at a woman like, let's say, these most vulnerable segments in northern Nigeria and Senegal, through pathways, we can also measure how likely are they to go to a facility. And what we see is that they're actually very unlikely to make it, probably only roughly 30% of those segments actually make it to the 4+ antenatal care visits that would be necessary to really ensure that she is taking her MMS. So ultimately, we're delivering this intervention. We want it to lead to the most vulnerable, but inadvertently, we're realizing that we're delivering it in a way that is actually not reaching the women it most critically needs to reach, because we've developed the product to be delivered through a certain mechanism, and those women aren't actually accessing that mechanism. And so that has serious implications for how you think about designing a product and introducing it into a particular type of delivery modality. I hope maybe that answered your question or came close to it.
Before we continue, I think there's some online questions, so
Yeah.
Anta, over to you.
Yeah, there's one really interesting one, Tracy, and I'm not sure if you were going to touch on that in the coming slides. Folks, attendees online are wondering if you have started implementing solutions to these issues in the regions you mentioned, and what results have been.
Yeah, so a couple quick examples. What we've worked in both Lagos and in northern Nigeria, and one of our partners wanted to develop a digital strategy for Senegal, actually. Sorry, for Lagos, that would actually better connect women with primary health care. And they did this because in Lagos, almost 80% of women report owning cell phones. When we looked into this a little bit more, many of these women actually don't own smartphones. They own feature phones. They actually like to use them for calling. At most, they want to receive an SMS. So the partner first changed its strategy. It moved away from this notion of digital first primary health care, and actually realized that in addition to digital, you needed to have those touch points, that if you were going to better connect women with primary health care, they needed physical touch points. So they developed a series of interventions, including market kiosks and pharmacy kiosks. So they still would deliver messaging through SMS, but then they would have these kiosk areas where women could go to ask for more assistance and ask for greater connection to primary healthcare services. They designed this using all of the data in the pathways profiles. And as they started testing these interventions, they actually learned that once again, they were missing, the market kiosks were successfully reaching the most vulnerable women, but the pharmacy kiosks were not, again, because the women in the most vulnerable segments weren't as comfortable going to pharmacies. And so they pivoted away from putting resources into the pharmacy kiosk kiosks and really went all in on the market kiosks as well as some other interventions. But hopefully that gives you like a quick example of how they use pathways to refine their strategy, to think about who they really needed to reach, to design the intervention, and then during the piloting phase, to make different types of decisions about which interventions they were really going to push forward with and which interventions they were going to drop.
Mika.
Hi, Tracy. Nice
Hi.
to meet you. My name is Emeka, and I was born in Nigeria, lived in Gambia for the past 10 years. So my question is, how do you use how does culture influence your segmentation? How does culture influence your segmentation? Because some of Hassan's story could be very cultural too, as well as an obvious reality. So how does culture influence your segmentation?
So culture influences it in a number of ways. It actually influences sort of the whole design of pathways. So when we create segmentation solutions, we are taking culture very much into consideration. And I'll give you an example from Senegal. We just worked with the Senegalese Ministry of Health. They actually wanted to create their own segmentation solution. And so we helped them with the methodology. And as we were going through and trying to figure out what were those factors that really produce vulnerability in a woman's life, we were working with them to really account for culturally what was the influence on some of those vulnerability factors. And so one example was the notion of polygamy. And initially, when the team was helping the Ministry of Health create the solution, we thought, well, polygamy is very prevalent. And so that should be included in sort of an understanding of what level of vulnerability this woman falls into. And one of the things they said to us was, actually, that's not the important factor, but the important factor is wife order. And this is in part because when often in Senegal, your marriage certificate is an important document. And oftentimes when women get married, even if it's the first marriage, the partners, the couple will choose polygamy. So they will actually check off that they're in a polygamous union, even though it's their first union. And so they keep that as an opportunity for the future. So what we realized is if we were thinking about polygamy as a driver of vulnerability, polygamy wasn't measuring what we thought it was measuring. And so we pivoted with the advice of the ministry to using wife order as the factor, because it was only then whether you knew, was that woman truly in a polygamous household. So even at that very early stage, we were using the notion of culture to help us understand what was driving that vulnerability. We also, in many ways, one of the things we're not seeking to shine the light on vulnerability to expose someone, but to really show that burden, that way that these more vulnerable segments of women carry that burden inequitably. And so we're using that notion of culture to help us understand, again, what are her burdens? And if we just even look at what's on this particular slide, you can see just the variance in terms of those most vulnerable women in northern Nigeria versus in Senegal, and where the burden is more inequitable, and ultimately where it's less inequitable.
Great, we're going to go to another question online.
Here's an interesting one, Tracy, stating that household decisions today do not only influence the current generation in women's health, but also health outcomes of the next generation. And this participant mentions India as an example. The question is, how can we create social and economic conditions that allow women in households to have equal say, ensuring that health equity is started at home?
That's a great question, and an issue that's yes, near and dear to my heart. I think one of the things that we have tried to demonstrate with Pathways, and I think it was in some ways it was a bit of a surprise to some in the field. What we saw was that when women are making decisions on their own, you know, we often sort of push for this notion like women should be able to make their own decisions. And of course, we want women to have choice. But when women are making decisions on their own, it's often associated much more with greater degrees of vulnerability. And that is because they're often making the decision on their own because they are truly alone and there isn't someone that they can rely on, or they're making that decision in contradiction to someone or something else. Again, someone else in the household, or to speak to the cultural question, the cultural expectations of that woman. And so we see quite clearly that we see lower degrees of vulnerability in households where women and men are making decisions jointly. And so one of the things that's pushed us to think about is how do we ensure that when we're delivering interventions, even when the woman is sort of the ultimate recipient of that intervention, how do we ensure that we're including the other important members within her social context in the discussion, in the understanding of why it is that she should experience a particular service or outcome or whatever it might be. So how we're taking that social context into consideration within all of the interventions that we design.
Do you have the last question?
Sure. Hi, Megan from Biodesign staff. A quick question about reading the data. So I can see the categories of vulnerability 1, 2, 3, 4, but some of the segments are labeled like 2.1, 2.2, 3.1, 3.2. How should we be reading those?
So what that means is that those women have the likelihood of the same level of vulnerability, but the drivers of that vulnerability are slightly different. So where we see that split in Nigeria, 3.1 and 3.2, it's interesting that it splits on normative issues. So 3.2 actually is a woman with very progressive gender norms. But as a result, she is sometimes left out of decision making. And we see her vulnerability at the same level in terms of the outcomes, because we do measure vulnerability based on the likelihood of her experiencing certain outcomes. She's having similar outcomes as an 3.1, who actually has internalized a lot of gender norms, so does not have very progressive gender norms. Interestingly enough, is included in a little bit more household decision-making than 3.2. But essentially, they're experiencing the same types of outcomes, but the drivers that lead to those outcomes are quite different. And just even from that example, I hope you can see that how you would intervene in those different households would need to be quite different based on the status that the woman holds within that household social structure.
Great. Thank you so much, Tracy. We don't have time for any more questions, I'm afraid, but thank you to everyone online who asked a question. So just to conclude, thank you so much, Tracy, for spending the hour with us and sharing your expertise. I think as people at Biodesign and for those online who are looking to design products to really do needs-driven innovation, I think this was a really helpful reminder that we can't just put people in categories that we assume are real, but that to really reach people in the way that they need it takes deep user research, and actually spending time with people to understand what are the vulnerabilities so we can segment well and ensure that our innovations really reach people who need it and don't further inequity. So thank you so much for your expertise, Tracy.
Thank you.
I'd also like to just thank our partners and to alert you to the fact that if you've missed previous Brown Bag sessions or Health Equity Innovation Series, you can catch them on our YouTube channel. They're all recorded. And our next talk will actually be on September 16th from 8 to 9 a.m. PST, so it's early. And that will be with Dr. Miriam Mustafa, and we're going to be talking about her work on contextual bias, AI, and innovation. And she's situated in Pakistan, and she's going to be talking to us about those issues. And then we have Indigenous Reclamation Through Innovation, Restoring Equitable Mental Health. And Jordana Saunders is going to be speaking to us about her approach to a mental health startup really focused on reaching Native Americans and how she's gone about doing the last mile health in America that we don't often hear about. And we really hope that these sessions encourage different perspectives, different narratives, and different voices to be lifted up in our community. So for those of you who joined us online, thank you so much. It's going to be the end of our webinar now. And for those of you still in the room, you're welcome to grab some food. And thank you for today.